Thank you. You guys are stuck with me for 3 days, so. Well, I don't know how I got stuck with this topic. I think I'm definitely not a pathologist, and I don't think we have pathologists in the house. Pathology is a very dry topic. But it is probably the most important thing that we would hear about, learn about, because it changes everything about net management. So I don't want to really give a long, boring talk. We'll make it a very short talk because I know we all want to hear Dr. Liu's surgical talk, which will be a lot more funner than this. So I'll kind of spare you some of, but I do want you all to understand the take-home message is these are the folks behind the scenes. We usually don't interact with them from the patient's perspective, but they are doing the most pivotal work. Because if they get the pathology wrong, we get everything wrong. The surgeons, the medical oncologists, the IR folks who are going to embolize, the whole management would be basically off the rails. And unfortunately, even in today's day and age, we see patients where pathology is sort of questionable because it is a rare tumor. In community where a pathologist might be expected to see all sort of cancers, and out of hundreds and thousands of breast cancer and colon cancer, if they are seeing one case of neuroendocrine tumor in a year, it's a possibility they might not understand the nuances of mixed neuroendocrine, non-neuroendocrine, or Ki67, or a large cell neuroendocrine carcinoma. So when you seek a second opinion in a large net center, it is paramount. Almost always we request a path re-review because we trust our pathologists because this is what they're doing for a living. They're hyper-focused on GI cancers and many times just neuroendocrine cancers. So, so why do we have to study pathology of neuroendocrine cancers? Because it's not an easy disease. It's not one disease, actually. It's a spectrum of disease, and that makes it very complex. It's not like colon cancer as adenocarcinoma, and you're done. So, and based on who is classifying neuroendocrine cancer, we have all these different gamuts of terminologies that we use. I've tried to simplify this for all of us here. So primarily, neuroendocrine cancers are in two big buckets: neuroendocrine tumors, NET, and neuroendocrine carcinomas, NEC. So T and C are the key words here. Tumor, carcinoma. Carcinoma more aggressive, tumor somewhat indolent. However, take it with a grain of salt because there are some well-differentiated grade 3 NET which could be aggressive. But those are two big buckets, and who determines that? It's not a medical oncologist, it's the pathologist. They will tell us, are we dealing with a NET or NEC? And if we mix these, it will change everything. Now, the way pathology's classifications work, there's a group called WHO, World Health Organization, and they kind of make these classifications for all cancers. So there's a lung group and there's a GI group, and sometimes it's very difficult for the community to come together. So you would see the lung folks like the terminology like typical and atypical carcinoma. These are two different flavors of NET when we are talking about the lung. But our GI folks, we are trying to move away from the terminology carcinoid because in the past it was plagued by implying benign tumor, and a lot of people did not get right care or aggressive care because it was thought to be benign, which we know that it's not always benign. And we are moving towards a more streamlined terminology, nomenclature. So we call NETs grade 1 well-differentiated NET, grade 2 well-differentiated NET, grade 3 well-differentiated NET. And we'll talk about how do we grade these things. And the NEC is poorly differentiated NEC. So that is sort of a commonality between lung and the GI world. But if you look into the real matter here, we are talking about the same cancer spectrum. be it lung or GI. It's a spectrum from indolent to more aggressive nature based on, increasing grade, and definitely the key thing was NET versus NEC, which is morphology. That's a fancy word of saying how the tumor look, okay? So let's go a little bit deeper into this. As I mentioned before, this is the current classification that we are using to label our diagnosis. When I started my career in neuroendocrine cancer, it didn't look quite like this. So in past, we had NETs, and there were only grade 1 and grade 2 NETs. There was no category called grade 3 well-defined NET. Any grade 3 tumor would be automatically NEC. We quickly learned that that's not the case. So these things evolved over time, and this is as recent, 2017. So you can see our field is still evolving. We are not really set in stone, and we are still learning, and I'll kind of throw some light on newer things that I expect would be imbibed in future iterations of WHO classifications. So this is how we currently classify neuroendocrine cancer. Two big buckets, NET, so well-differentiated NEN, so you can see on the top, and there are three different flavors of it, grade 1, grade 2, grade 3, based on what? Two major things. You see right next to grade 1, grade 2, grade 3 is something called as Key 67. I recently learned it's called Key 67. I used to call it KI 67. Can you believe it? Well, we all learn. So Key 67 is the most common marker that we use to classify grade 1, grade 2, grade 3. But there's also something called as mitotic index. And some pathologists would report that. And that's fine. That's a different way to analyze the cell count in certain high-power fields. One thing to note, though, if there is discordance between maybe two different sites of biopsies, and one's reporting 3%, one's reporting 5%, or one's reporting Key 67, which goes in grade 1, but mitotic index grade 2, we always go towards the higher end of the spectrum. Okay? You do not want to undermine the disease. You go and for practical purposes, the diagnosis would be whatever is the highest category. Okay? On the other end of spectrum is NECs, the poorly differentiated neuroendocrine carcinomas. And in the next slide, I'll show you why do we say the well-differentiated poorly, what is the whole fuzz about. But there are two major subcategories of these poorly differentiated neuroendocrine carcinoma. One is small cell, other one's large cell. We did give a little bit talk about these two subvarieties yesterday in our high-grade session. Dr. Starr did a phenomenal job there. But sometimes it's just not, it's so de-differentiated that the pathologist is unable to classify whether it's large cell or small cell. So they will just leave it at poorly differentiated neuroendocrine carcinoma. So some of you might relate to that. So don't worry, it's not always possible, just because these tumors sometimes can be so aggressive and lose all their characteristics, and we can't really subclassify them. But for practical purposes, they're all sort of treated in a very similar way, all NECs, okay? Let's move forward. So this is something that we, as oncologists or other specialists, we don't have to deal with it. Thank God we don't have to slice the tissue, the biopsies, and stain them, look at it on the microscope. Tough work. But our pathology colleagues do it for us. We do get to see this in tumor board discussions, where when a case is presented, the first thing that we discuss is pathology, and the pathologist would show us the slide, blow it up in the big screen, and tell us, hey, this is why he or she thinks that it is a well-differentiated neuroendocrine tumor. It is a grade 1 tumor because this is the Key 67. Or there are these high-risk features. There is some necrosis there. Or there is involvement of the margin there. So all those things really help us and kind of paint an appropriate picture of patient, right? So this is the slide denoting NET, well-differentiated neuroendocrine tumor. Especially on the B side, you can probably appreciate that there are these islands of cells, right? These are glandular patterns. This is how a neuroendocrine tumor should look like. So there is a pattern there, okay? As compared to, just for the contrast, and poorly differentiated, there is no pattern. It's sheets of cells. So maybe you can have some appreciation why we say well-differentiated net, well-differentiated versus poorly differentiated. There's no pattern here. It is just sheets of cells because this is very aggressive cancer. It's just growing, growing, growing. But well-differentiated has an actual pattern. There are different types of pattern. This is one type of pattern. But you can actually see the character of neuroendocrine cells maintained. Although these are tumors, it's growing. It shouldn't be growing that much. But they're still maintaining their character. They're still forming the same sort of glandular patterns, okay? So this is a very simplistic version since we are not pathologists, okay? The other important thing, so once the morphology, that means the look of the cells, they determine whether going to the NET bucket or NEC bucket. The next thing is, once we have ascertained that this is NET, what's the next step? We need to know the key 67 or the grading, because grade 1 NET would be treated completely different than a grade 3 NET, right? And how do we do that? Again, the pathologist comes to the rescue. So in the middle, there's the bluish slide you see, that's actually staining for key 67. This is a low-grade tumor. This is a grade 1 tumor. So what do you expect? The key 67 should be under 3%, very minimal. It should hardly take any key 67 stain. And that's what we are seeing here. There's hardly any staining of the slide. The stain is actually brown. Let me show you contrast. In high-grade NEC, where key 67 is usually very high, by books should be anything more than 20%, but a small cell cancer would usually have 80, 90%. So if you see here, the center of the slide, it's all brown. It is massive amount of uptake of the stain, right? But in a low-grade tumor, hardly any stains there. So that's how the pathologist would calculate the differences between what is the pattern, and that's how they grade 1 versus grade 2 versus grade 3. And this has clear implication in how the patient would behave. This defines the biology of disease. We know from our population studies that the survival, the outcomes for grade 1 is different as compared to grade 2, is different as compared to grade 3, as compared to NEC. And if we get this wrong, we will get the tempo wrong, we will get the urgency wrong, and everything would be basically derailed. So coming to the morphology, the looks of NEC, as I mentioned before, that there are two big subtypes, the small cell and the large cell. You can probably easily guess. The small cell, you can see small, round, blue cells on one side of the screen, and on the other side is a large cells. So it's literally verbatim, small cell, large cell. So a lot of cytoplasm, very little cytoplasm, but there is no pattern. There's no glandular formation. These are poorly differentiated. Okay? There are sheets of cells that's growing constantly. And if you look in the middle, the key 67 for these, very high. Okay? So technically, they can have key 67 ranging from 20% all the 100%, but in small cell cancer, usually the key 67 is over 80%. Large cells are a little bit more trickier. We have seen some large cell with key 67, 30, 40s, but usually they would be also over 50 and somewhere between 50 and 80. So those are the nuances that helps us understand the biology of disease so that we can get on the right track. And that's the current evolution of how we grade and classify these tumors. Now, this field is moving a step forward. This is not ready for prime time yet, but I anticipate in maybe next few years, this will be sort of almost formalized as standard practice. And what am I talking about? So yesterday I talked about genomic sequencing, genetic testing. So we can have 2 patients with grade 1 NET, grade 1 NET, or 2 patients, neuroendocrine carcinoma patients, but you'd be surprised if we sequence the DNA of their tumors, it would be very different. So every patient is very unique. And that is why for some patients, PRT might be good treatment, it works great, and for other patients, Afinitor is working great, because there is tumor heterogeneity, and different patients respond to different treatments. And that's why zebra is such a good mascot for us, because no 2 zebras have same stripes, right? So you can have same diagnosis, but you might still have a difference in the tumor genetics, which dictates how your tumor would behave, how your tumor would respond to treatments, etc. And our understanding of this is still in very early stages, but we are at least making some strides there. For example, especially for high-grade neuroendocrine cancers, like large cell neuroendocrine cancer, I showed this slide yesterday, we now know the genomics of high grades really subcategorizes them into 2 big buckets, the small cell-like and large cell-like. So if you look at here, there are certain signatures which are very classic for small cell subtype, like mutation in TP53 gene, loss of RB1, and then there is some non-small cell-like cohort. Similarly, for well-differentiated NET as well, this is some of fantastic work from a world-renowned pathologist, Dr. Tang in Memorial. And as you can see, between the different grades of the tumor, spanning from well-differentiated to NEC, poorly differentiated, if you look at the last line of the slide, the mutations, they vary, right? So we have a clear distinction between how NEC biomarkers would look. We'll see RB1 loss, we'll see TP53, but in a well-differentiated category, it's a completely different set of mutations that we are seeing. We are seeing loss of DAX, loss of ATRX, and mutations which we often see in mTOR pathways, etc. Is this ready for prime time? No, not yet. So I won't say that we need to sequence everybody to classify their tumors, but this is coming up. And especially for high grades where the diagnosis is always very challenging. And there are a lot of times where we'll have patients who send to us for a high grade second opinion and we end up changing their diagnosis. That is where these objective genomic biomarkers would help, because you can't really misinterpret that. It is either you have that mutation, you don't. So I think there's a growing role of getting genetic testing and all of this, just something that we are looking in the horizon. So with that, I would like to stop here. And if you guys have any questions regarding pathologies, we'll be happy to address them later in Q&A. Didn't want to kind of prolong this too much, but I do want you to know that our pathology colleagues, which you never usually see, but they do very important work. In fact, the most important work. Without their help, we can't really do what we do efficiently. So thank you so much.